Good morning. This is Professor Shukr, and I'm going to talk about is carcinoma rectum. So first we must understand the anatomy of the rectum. So what is the division of upper, middle and lower rectum? The length of rectum is 15 centimeter. Now this is established 15 centimeter, not 12, 18 and other according to surgery update. Anal canal from anal verge is 0 to 4 centimeter. Distal rectum is 4 to 8 centimeter. Middle rectum is 8 to 12 centimeter and upper rectum is 12 to 15 centimeter. During operation, when rectum is mobilized, then to this length 3 centimeter or 4 centimeter can be added. It means this thing, the lower half up to 10 centimeter can be felt by digital rectal examination or proctoscope. Usually, the length of the finger is 7 centimeter, so up to 7 from the anal verge up to 7 centimeter it can be felt. But when you ask the patient to exert, there is little descent, and from anal verge up to 10 centimeter it can be felt. Proctoscope is a misnomer. In proctoscope, whole rectum is not seen. It is the whole of the anal canal is seen and the distal portion of rectum. Full rectum cannot be felt by digital rectal examination or seen by proctoscope. For that, we required a fiber-optic colonoscope. By means of rigid sigmoidoscope, which is 25 centimeter, one can see the sigmoidoscope. One can see the rectum. Now, as you know, the symptoms of carcinoma rectum are bleeding per rectum, sense of incomplete defecation, early morning stool frequency, also called as spurious diarrhea, mucus and pus discharge. Tenesmus is when a patient has a feeling to pass the stools, he goes, hardly nothing happens or anything happens, but patient feels distress, patient feels pain. In Duke staging, when we are talking about, A is limited to wall, does not breach the muscular propria, B is across the wall, and C is involved lymph node. TNM classification, T1 to submucosa, T2 muscularis propria, T3 outside muscularis propria but not breaching serosa, T4 breaching serosa directly involves other organs, N1 no lymph nodes, N2 1 to 3 nodes, and N3 4 or more nodes. M0 is no metastasis, M1 is if metastases are present. As far as diagnosis and assessment is concerned, in all cases of suspected rectal cancer, digital rectal examination is mandatory. Carcinoembryonic antigen is the tumor marker. Sigmoidoscopy should be done, preferably rigid, but flexible could be done, and biopsy should be taken. Colonoscopy is required. If it's not possible, then CT, colonography or barium enema. For a proven rectal cancer for staging, imaging of liver and chest by CT scan, local pelvic imaging by MRI, and if endoluminal ultrasound is available, then that may be done. Once we have diagnosed a case of carcinoma rectum, the neoadjuvant treatment should be given. For locally advanced cancers, it includes a short course of radiotherapy preceded by chemotherapy, which is FOLFOX and CAPOX, which is recommended. The principles of operation are radical excision, it means en bloc removal of tumor with its lymphatic drainage. In rectum, there are two operations. One is abdominoperineal resection and other is anterior resection. Whether we are doing abdominoperineal resection or anterior resection, total mesorectal excision is recommended and high ligation of inferior mesenteric lymphovesicular pedicle is done. Important thing in carcinoma rectum is while we are removing it, then one must see the ureters. Ureter is important when we are excising the rectum. In preoperative care, the important things are that anemia should be corrected, there should be counseling, bowel preparation should be done, thromboembolic prophylaxis, which includes anti-embolic stockings, low molecular weight heparin, and antibiotic prophylaxis, which is done at the start of the surgery by giving broad spectrum antibiotics covering gram-negative and anaerobes. It is important to mark the stomachostite before the site of operation. It should be away from bony points, away from scar, away from belt wearing band, and away from umbilicus. It should be through medial or lateral edge of rectus abdominis and should be on the top of a fat fold if it's present. How to prepare the bowel? If you see this thing, it has evolved to stages of mechanical or antibiotics. Then there was a time when many people were not doing gut preparation, even now they are not doing, but American College of Surgeons guidelines recommend that it should be done and it has advantages. What we should do is take 4 liters of water and add 32 sachets of Movicol, which is polyethylene glycol solution. Given a day before preparation at 4 p.m. and is drunk by patient in 6 hours, meaning by every 15 minutes, ask the patient to drink 1 glass. One day before, breakfast is given, which is a light breakfast. After, only clear fluids are allowed, which may include water, kava, 7-Up, etc. And patient is kept NPO. And once Movicol is given, after that antibiotics are started. In oral antibiotics, either give neomycin sulfate 1 gram and erythromycin 1 gram, or you can replace erythromycin with metronidazole, give neomycin sulfate 1 gram and metronidazole 1 gram. Neomycin is available in Pakistan as lavenda 500 mg tablet, and metronidazole is available in Pakistan as Flagyl 500 mg tablet. Now when we talk about the operation, the principle of this thing is in carcinoma rectum, once we excite the rectum, then the point of excision should be 2 centimeter distal to the tumor. Not only this, some sleeve of rectum should remain attached to anal canal so that colocolic anastomosis can be made. So how much sleeve should be left behind? Minimum 2 centimeter if we are using a gun, or 4 to 5 centimeter if we are making anastomosis by using the hand. In simple words, if on digital rectal examination tumor is not felt, then it's a candidate for interior resection. If tumor is clearly felt and is involving the anal canal or not involving the canal but is felt clearly, then it is a candidate for abdominoperineal resection. So therefore, in other words, tumor which are present in the lower one-third of the rectum, not in the middle, in the lower one-third of the rectum, and if they are 4 centimeter from the anal margin, meaning only anal class is left, go for abdominoperineal resection. But if you can feel it at the tip of the finger, then it is 6 to 7 centimeter away from the margin. So therefore, one can go for either APR or one can go for a low interior resection. If one thinks that there would be some compromise, such as 2 centimeter distal the tumor, that would be compromised, or adequate mesorectal excision would not be done, or the tumor is highly aggressive, then obviously abdominoperineal resection is more appropriate than interior resection, and rest interior resection should be done. After that, there is a role of chemotherapy. One should give Folfox or Capox, or one can use 5-fluorouracil and leucovorin. Those patients which present with obstruction, the priority is to relieve the obstruction and save the life of patient, and not excision, resection of the tumor. But if resection of the tumor can also be achieved, then that is the first priority. So therefore, the options available are resection. If resection is not possible, then one can do bowel bypass, or if that is also possible, simple diverting ostomy can be done. Stenting is possible only for upper rectal lesions only. So therefore, patient with obstruction, the objective is to relieve the obstruction, and resection of the tumor should be tried. If it can't be done, then that is additional point. And then obviously after that, the tumor is treated on its own merit. Is a tumor with good prognosis, especially Duke A is 90%, Duke B 60 to 70%, Duke C 30%. Overall, one can say round about 50%. Now, how to do follow-up? One should use using carcinoembryonic antigen levels and performing ultrasound and digital rectal examination. Colonoscopy is done if there is any red flag like carcinoembryonic antigen is raised, patient has developed new symptom, or abdominal ultrasound shows an abnormality. First, follow-up is done at 3 months interval, then 6 months interval, then yearly. This is a short summary of carcinoma rectum. Thank you very much.